The broadcast is now starting. All attendees are in listen-only mode.
Hey, John.
Hey, I'm here.
Okay, hey, it's Vicky. I'm hearing a lot of static. Do you?
Yep, I think that seemed to fix it.
We're going to wait a few more minutes for more people to join. So at that point, then we'll have John start the program, but it'll just be probably another minute or so.
Okay.
Okay, everyone, in the interest of time, I don't want to keep everybody busy. We're going to go ahead and get started. Just so you know, those who are listening, you all are on mute. We will open the lines at the end of the presentation for questions. You can also put them in the box. We're using the webinar platform, even though it's more of a meeting, but it was just better for the presentation. And then, so from here, we'll have John start the program. And then, like I said, we'll take any questions at the end. All right, John, you can take it away.
Okay, everyone, thanks for inviting Vicki and I to come and kind of review what grade methodology is. Let me preface the start of this with, we could spend an entire 2-day program actually digging into what this is. So what I've tried to do is condense it down to an hour or less of kind of a 50-foot overview of what grade is, and then that maybe we can have some discussion at the end on how this could be applied into nursing guidelines. When you're looking at the grade methodology, in 2008, there was a first comprehensive guide to how to use grade methodology. It kind of started out kind of slow, and then as more organizations picked up on using this as a way of looking at how they develop guidelines, people like EAST, Society of Critical Care Medicine, World Health Organization, those kind of groups decided to embrace the process and to work towards making that their standard for dealing with guidelines. What it does is provides a framework for both the rating of the quality of the evidence that you find and how you can apply this evidence to the development of a practice management guideline. One of the goals is to move away from ones that rely mostly on expert opinion and move towards actually harder research that proves what it is we need to be doing or what we do not need to be doing. It is supposed to be a transparent and systematic literature assessment. As we go through, you'll understand a little bit more about how this differs from what we've always done. So when you're looking at what is grade, it's grading of recommendations, assessment, development, and evaluation. It is a system where you rate the body of the evidence in a transparent process, and it differs from the way we mostly learned in grad school or doctoral programs on how we want to conduct research and come up with answers. The grade process doesn't actually look at hypotheses or null hypotheses. What you decide on here as we go through and look at it is you start with whatever the interest is that you have. If it's developing a guideline for care of the splenic injured patient or one of those kind of topics, you start with what it is that you want to look at. Then as you move through the process, you get down to ultimately being able to determine a guideline and what is supported in the evidence and the literature for what you're trying to do. I want to preface this next slide is very busy, but I'm going to kind of break it down. But this is kind of the way it goes. This is a schematic view of what the grade approach is for synthesizing evidence and how to develop recommendations. It looks very busy with a lot of different stopping points. And to be honest, it's a very laborious process when you first get started trying to use this and apply it in developing your guidelines. In brief, what you do is you determine a topic of interest, you assemble a multidisciplinary team. And this is where it becomes important that, for example, I'm currently heading up a PMG revision that has to do with endotracheal intubation in the trauma patient. Well, for this to be a valid practice management guideline, we have to pull in disciplines from the emergency medicine side, critical care, as well as anesthesia. To have it truly multidisciplinary, anyone that could be impacted by the guidelines should be offered the opportunity to participate in the development up front. Then you develop your Pico. You look at a systematic review and meta-analysis of the data that's out there, rate your evidence, create evidence profiles or a summary of your findings, determine what your recommendations are going to be, and then you go and look at preparing the manuscript. And we'll talk a little bit about them as we go through. So why do we develop guidelines? Well, I think most of us develop guidelines to, one, assist in clinical decision making, and to make it more applicable to a group than just an individual preference. We also use them to educate individuals or groups, as well as assess the quality of the care that we're providing. It also helps to guide allocations of resources, and in ultimate fashion, it will reduce the risk for legal liability when we have a standardized guideline that is evidence-based that we can back up with literature should that ever come up. So, overview of the process. When you're looking at establishment of the process, this is probably one of the more difficult tasks that I have found as I started moving through this. is deciding how you're going to put together the team. And keep in mind, one of the things that scares a lot of people off when they're looking at doing PMGs, especially using grade, from inception of the idea to actually a finished manuscript often is about 18 months. A year to 18 months is the timeline. A lot of times we want things in a much quicker fashion, so sometimes applying the grade methodology might not be the avenue you choose to take, but it is the proven one, and it's the one that East has supported and has done very well with. Then we did the synthesis of the evidence. Most of us that went to grad school or finished our doctoral programs, we were the researcher. We did the literature reviews. We did the analysis of the data that we find. When you're using something such as grade, it's recommended to have a thorough search done of the literature using all of the available resources, and we could get into a whole 2 hours on that. But essentially, a medical librarian or someone who is very versed in the various databases should be employed in the group there to work on establishing what's going to be your parameters for searching, and then how you're going to narrow down what it is. And we'll talk a little bit more about it. Then the development of the recommendations. We are in the final revision of a manuscript on a PMG that we had been working on. It actually ended up being a evidence-based review of geriatric trauma that should be going out for blind review in the next, probably a month or so. This process we started in the summer of last year, and there was already a guideline in place. It's just we were trying to see what had changed and what was new. And then additionally with that, what additional Pico questions that we might want to ask. So when you're looking at overview of the process, this is kind of the 3 broad categories of things that you're going to get involved with when you start looking at this. So when you're looking at establishment of the process, what you want to ask yourself is, what is it you're trying to find out? Do you want to know if a patient fares better having non-operative management of a splenic injury versus operative? And which are your parameters for each? What is the questions that you want to be answered? These generally, with the Pico format, and we'll talk about that in just a moment, it comes down to your population, your intervention, your comparator, and then what is your outcome. The outcomes generally are the last part of the process. Once you figure out what it is you're trying to ask, then you can get into what's going to be the outcomes. Creating your work team is very important with you. If you're doing something outside of your institution, such as like the East PMG committee, one of the struggles you have is everybody's on a different schedule. I have people on our committee that are from California. I'm located in Florida, so finding a time that works for everybody sometimes is a challenge. And it is recommended that you set yourself a timeline as you're doing this. If you're going to work on something, how often are you going to meet? Minimum of monthly is really important to think about. Actually, even twice a month if you're really in the early stages and you're having struggles getting your head around what it is you want to do. Agree on who's going to be the team leader, and the team leader in this instance does not mean the one doing all the work. It means the one that's kind of driving the process, staying on top of the timelines, and making sure the deliverables are there. But everyone in the group should participate. And then if there's any declaring any conflict of interest, that's important to address up front in the process. Otherwise, if you miss declaring any conflict of interest, it could hurt the validity of what you end up deciding to do. So when we're looking at synthesis of the evidence, formulate and define your Pico questions. And here you think about the population, the intervention, the comparators, and the outcomes. And unfortunately, a lot of times we miss on the outcomes. We have to look at every possible outcome and decide what it is that we're trying to address. Unlike going to work on a project and say, okay, I want to see if a sleep program would reduce delirium onset in the ICU. So you go in and you start looking at sleep or delirium in the ICU, and you kind of gather your evidence that way. Well, looking at this using a Pico format as far as an outcome, would it make it sleep worse? Would it make it better? Does it not affect it at all? Is there confounding factors like medications being used? You have to really broaden what it is that you're looking for when you're looking for the outcomes to make sure that you're gathering all the information that's available. When you're looking at your Pico questions, they should be very specific. I can send examples. I was going to put some in here, but in the essence of trying to get this down as short and sweet as I could, I thought we would save that to another time if there's interest and we want to move forward with looking at this. It should be outcome-centric, so you have to have a strong outcome to guide the question, which will further guide the literature review. And then when you're guiding the evidence review, this is when you want to make sure that all possible areas have been covered and looked at in the literature. One of the things I think looking at the Pico questions in the grade format that was difficult for me to grasp is it's okay to go through this entire laborious process to figure out that there's not really any data that supports a recommendation. That was kind of hard for me in the beginning because it's like you get to the end and you have determined there's no evidence to support what it is that you're doing, or you can't recommend what it is that you're doing, but you spent this entire time looking for that needle in a haystack that says, yes, this is what we should be doing. General principles when you're looking at your Pico formation, we talked about considering all your outcomes. You'll rate the importance of each one of the outcomes, and I'll show you the scale. But essentially, are they critical outcomes? Are they important? Are they less important? There's a 9-point scale for making a decision, and this is what you include in your final evidence profile, and this will help define the overall quality of the evidence based on each Pico. And this is kind of what they look at. Critical outcomes. In this example was classification or outcomes for embolization of blunt splenic injuries. Should we not? What are the critical outcomes that we're looking at? And you can see down the right-hand column, starting with 9, we don't have a number 1 for this one, but mortality, that would be a pretty big critical outcome, all the way down to less important things like need for narcotics. But you're looking at every possible outcome involvement that you have there, and then you'll rate those on what it is that you're looking for that are most important. When we talk about the systematic review, it's modeled from the Cochrane system, and when you're looking at that, it's very rigorous and protocolized. And what I mean by that is you have a document that says, I am looking at PubMed, whatever other databases you're using, and these are the search terms that I put in to yield the data that I'm going to be reviewing and talking about. And your software, things like EndNote and ReferenceWorks, are really important to include as you go through this. It will help you as you get further down the line to developing your manuscript and having your references. We'll talk briefly about Redman and GrayPro. There are 2 separate software systems that kind of help with an analysis of the data and presentation of the data. And it's kind of a central point that you can put in and use to get the evidence tables that some of the journals require, like Journal of Trauma requires that you have evidence tables. So it's important that you are aware that those systems are out there. When you're looking at extraction of your data, Prisma stands for the Preferred Reporting Items for Systematic Reviews and Meta-Analyses. This is a diagram that I'm going to show you that kind of goes through, and this is included in your final manuscript. There's 27 separate points of a checklist when you're looking at what it is that you're evaluating and extracting from the record or the reference that you have found. And this is kind of what it looks like. And this was the 2009 version, but it kind of gives you all of the records that were identified, and it gives you an opportunity to list and justify which ones you kept versus which ones you didn't. And then if you're ever evaluated on why, you can say this did not meet the final search criteria, or I was looking at, for example, whether or not palliative care should be included in an order set for trauma patients. And none of these articles actually talked about order sets. It talked about palliative care referrals. Whatever it is that you're looking at, this gives you a way to organize it and also to be able to present it if you're ever asked about it. Meta-analyses. When you're looking at meta-analyses, not all your systematic reviews will yield a meta-analysis, since a lot of times the studies are not amenable to being combined. Every meta-analysis should follow a rigorous systematic review. You want to pull the articles with like Pico questions and similar natures that you can actually make a more bold statement about and consider a recommendation for or against based on doing the meta-analyses. Common outcomes reporting, you look at things like your odds ratio or your relative risk, and those will be included in the methodology section of the manuscript or the document that you end up developing. Remember, the odds ratio is the odds that an outcome will occur given exposure to a certain intervention. It's a way to look at check and balances and to add more validity to the overall study that you've reviewed and what you're doing as far as guideline development, making it evidence-based. We briefly mentioned a moment ago Redman and GrayPro. Redman facilitates the preparation of your protocols and includes things like your characteristics of your study, comparison tables, and study data. It also can perform the meta-analyses for you if entered correctly and give you a graphical result of it. The GrayPro is an updated version of a previous, this one is actually GDT is the current one. But GrayPro essentially helps you to produce your evidence profile tables. Most of the journals, scientific journals, require that you have that, and it's a part of a manuscript if you're looking at publishing it. They actually interface together if the data is done correctly. The problem with it, if you put bad data in Redman and you try to interface with GrayPro and you find an error, you have to go back and start from scratch. You can't actually go in and correct it. That's one of the downfalls that you hear a lot of people discuss. So when we talk about grading the quality of the evidence, we talk about listing it as high, moderate, low, or very low. In order to provide consistent categorization of the evidence, the grade uses these four recommendation grades. High is example, it's very confident that the true effect lies close to that of the estimated effect, all the way down to very low, which there's little confidence that the effect estimate or the true effect is likely to be substantially different. It's a little different and another process from what it is that we've done in the past, actually grading the evidence. We've looked at evidence, but it's not always been used in a format to where we actually have to grade it and decide if this is good, bad, and actually assign a numerical value or a numerical name to it. When you're looking at a process of rating the quality of evidence, you look at the study design, you look at the quality of the body of evidence. Is it a random controlled trial? Is it an expert opinion? Is it an observational study? And all of that goes back to the hierarchy of evidence. And when you look at it, you want to rate lower or higher based on things listed that we could discuss at another time, but essentially things like risk of bias, risk of study effect. Is the size big enough to be applicable to a general population? If it's a small sample size, that could be an issue. And then what is the quality? How was the study done? Has the study been reproduced? Is it a follow-up to a study previously done? And your rating numbers can go up or down based on looking at all of the information. And what you want to come up with at the end is whether or not this was a strong recommendation or a strong study and rated high, or if it's something very low. The evidence-based review that we did with the geriatric, I want to say, and I may be a couple of numbers off, we had 70-ish articles that we actually all had to review and rate evidence on. And what we found out that there were several of them in there that just did not carry any weight. They were included because we did the review on them and they were part of the literature search, but they really just didn't carry weight when we were looking at being able to make recommendations. Probably seen this somewhere before in your studies along the way, but this is actually the hierarchy of evidence. Systematic reviews and meta-analyses are at the top. You can see the very bottom is when you get to the expert opinion. And when you're listing this, and as we read studies and recommendations, we should keep this in the back of our mind to what is the strength and what is the hierarchy of this evidence that we're looking at. If it's, systematic reviews, if it's random controlled trials, that carries a lot of weight. That makes it a little easier when people read it to go, okay, they've done their work and this is actually something that we should look at, versus that we make a recommendation based off observational or descriptive designs. When you get to creating the recommendations, this process took us probably 3 months on the EBR that we did. And we have differencing in opinions, I guess, on some of them. So when you look at it, what it wants is when you make a recommendation, you want to determine how strong this recommendation is, and it's done distinctly away from rating the quality of the evidence. The primary rating is what is the overall quality, and to balance the benefits and harm or burdens to patients, and look at what your resource considerations are. In grade, there's only 2 levels of action. It's either a strong recommendation or it's a weak recommendation. The strong recommendation is this is when you have desirable effects, and they clearly outweigh the undesirable. And we use phrasing like we recommend or we recommend against based on positive, negative, which one it is. The second one, weak, this is kind of a conditional recommendation. It's used when the trade-offs are less certain or you're not really sure. And you can occasionally get to the end of your process and realize that you really have no strong recommendations. Or if you do, it's going to be recommending against something versus recommending for it. This was a little change as we started moving through and looking at things. And it's okay to have a weak or a conditional recommendation if the data and the literature doesn't support what it is that you're looking at. So don't worry if you get to that stage and you can't find anything but weak or conditional recommendations. Gaining consensus, this is always the fun part when you've got people voting on outcomes and what it is that you are going to accept or and recommend or not recommend. Making a recommendation, it's the strength of the recommendation, and you want to go through and look at it. 50% of the participants needs to be in favor of what it is that you're proposing as a recommendation, and no more than 20 against the alternative, which would be either to intervene or not intervene based on what you're doing. Strong recommendations do require at least 70% of the work group to vote for it. So once you get through the grading process and you make your recommendations and gain your consensus, now it's time to start thinking about writing it up or writing your manuscript. This can be a very tedious task. The one that I did recently, we actually divided up sections of the manuscript, and we had one person that actually went back through and tied them all in together. But when you're looking at it, just to give you an example, here's the portions of it. You have the title, the abstract, an introduction, what your objectives are, your Pico questions, the identification of what your resources are, and your outcome measures. Then you go to how was the data obtained, what search did you do, how was it extracted, and what methodology was used. And then for each Pico question, you list all of the following information. You grade the evidence, make the recommendations. And it's the summary portion of it. This is how to apply what we've just given you in this PMG into clinical practice. And then, of course, the conclusion often is additional research is needed, or this variable should be considered when doing further research, getting down to the actual end of the manuscript. So kind of in a nutshell, that is a quick overview of grade. It starts with deciding there's a clinical question that you want answered. And with that, then deciding what group needs to be assembled. Once you get your group assembled, then you think about what are going to be the PICOs. And often, the first couple of times that you meet, the PIC portion, the STEM, is where you get to. The outcomes, a lot of times, are a little more difficult to narrow down and focus on. So that sometimes presents a challenge. After that, you think about how you're going to gather your data, who's going to do their literature review, what are you looking for, and as you go through that, you get your data, you send it out to the group. The group looks at the articles and rates the evidence that you got, and there's forms that you can use to do that. I just didn't want to include them in here. But there's definitely forms that you can use. And once you rate the data, then everybody comes back together and you start looking at what recommendations can we make either for or against based on the data that we have. Once we make the recommendations, then you go through and you start thinking about how to plan out the manuscript. Manuscript, as I said, from start to manuscript sometimes can be 18 months if you're starting from something that's not been really reviewed, or it's a new PMG that East has not done. If we've done it before with an update, it may not take the 18 months. I'm looking at probably a year for the one that we're doing, just because of getting everybody together and where we're at in the process of the group at this time. So with that, what I wanted to do was, think about the East and STN Collaborative. I think that this is a great opportunity for the two to work together. If you think about it, we're both one team. Vicki and I both are nurses, so we definitely get the nursing aspect of it. But it's also an opportunity for everybody to kind of sing and dance off the same page of music. And even in my own institution, we struggle sometimes with medical guidelines versus nursing guidelines, and they don't always complement each other. But we all have the same goal, which is to improve the ability to care for the patient that's been injured. And I think we can do that best by evidence-based practice and figuring out how we can all work together and develop guidelines that complement each other and are interworkable. So where do we go from here? Vicki and I had talked with Linda. We had a couple of conference calls, and we had looked at the current East PMGs and kind of made a little list of what might be easy to narrow down and change into nursing guidelines or to bridge off of into nursing guidelines. But I think one of the things was determining what are the priorities for STN. If there's hot topics that is really on their burner that they need to do something with, then that may be where we need to start. And then our first thing after that would be to develop a work group. With that, I will open up to questions.
Okay, I'm going to unmute everybody in just a moment, please. I will unmute you, and then you can ask the questions. Okay, everybody is unmuted, so please ask any questions you may have.
Okay, then I'll ask the first one. Did this give a little better understanding of what grade is and how the process works?
Well, the short answer to that is yes.
Long answer is it's a lot of information.
Right. It's a lot to kind of take in when you haven't walked through the process before. So it's a lot to take in.
I agree with that. That's why I didn't want to get too detailed in some of it. As I was putting the presentation together, I thought, my goodness, I could spend 3 hours on just developing your Pico question. And if you read the documents that are on the East website, it's a little tedious to read. There's a couple of articles out there that kind of summarize it in not quite such a heavy fashion. I think it's a good process, but I'm still learning. So it's a process that was very, very new for me as a nurse.
Yeah, this is Vicki. John, great job in summarizing. Just excellent presentation and trying to give us an overview. The one thing I would encourage everybody to do is not to be discouraged, because it is a complex process. It's a new way of thinking, but it also can be a very exciting time to try to align some of these guidelines and develop some nursing ones along with the East guidelines that are already in existence. And I think probably one of the biggest things that we need to determine as far as the work group is who really has an interest in this going forward and who wants to do this. I think because many times wanting to do it and having an interest in it spurs us on to learn it and make it successful. So I think, what we're looking for is partners that really want to learn and do this and make it a successful project.
I think that's very well stated, Vicki. I agree with you. When you first start getting into it, Vicki and I were actually talking, I guess it was last week, Dr. Como, who's the chair of our PMG group, one of the things that's just expected if you're working in this group is that you're going to work. So it's like we end up with, items to take care of and follow-up to do, and having the timeline. I was very fortunate to work with Dr. Marie Crandall on the evidence-based review. And she is one of these timeline-driven chairs or group leaders that kept everybody focused. And we continually were doing something, it seems like, with the EBR for many, many months. But it seems to work that way. Starting out without an end in sight or a timeline, I think with the grade particularly makes it very difficult. Well, I am open. I've left the slide up that's got Vicki and my emails. If you have questions, feel free to reach out to us. If we can't answer it, we'll get an answer from one of the group, one of the people from our committee. I just wanted to try to give you an introduction and kind of show you the pieces without getting too detailed. As I said, you can do a 2-day course on this. I think the videos on the East website are about a day long if you do each one of them. So if there's no more questions, I won't keep you. I know everybody's got things to do. But I do appreciate you inviting us to come and talk to you about grade, and I think we're both excited about the opportunity of possibly partnering and working on some nursing guidelines.
John, I do have a question. Are you there?
Yes, I am. Yes, ma'am.
Okay, I'm so sorry. Okay, so with this grade methodology, is it the grand I guess my question is like just getting started in it. Do you develop that Pico question pretty close to the beginning? Like,
yes,
okay.
Yes, and that's the part that was a big shift for me, is figuring out the questions instead of, in what I did, for example, in my doctoral program, is I knew what it was I was looking for, and I went looking for literature to support what it was I wanted to do. Here, you develop what it is you want to do, and then the literature guide where you go from there. Either you do it or you don't do it, which was just a very big change for me.
What do you mean by saying you develop what you want to do? What I don't understand that.
Okay. For example, my research project in my doctoral program was determining if a sleep program would impact delirium onset, i.e. positive delirium screening in the ICU, as opposed to not having a program, and seeing whether or not there was any change in the onset of delirium with mixing up and patients not having designated sleep periods. So I knew what I wanted to do was to look for literature that supported sleep programs, delirium reduction agents, or mechanisms when I went to looking at how I wanted to support what it was I was doing, which was developing a sleep program. So it's a little different here in that I want to answer the question, for example, like the one with the splenic injury. Does angioembolization affect the outcome in the splenic injured patient? And if so, what is the outcome? What we go through and look with this is you're doing the search and you're looking at the angioembolization, splenic injuries, non-operative management, operative management, looking at all the possible outcomes. And then what you want to hope to get to at the end is we can recommend against, or we recommend for, early angioembolization. So you get down, and these are things you want to have answered. And wherever the literature takes you, it may not support that. And this is not a good example of what it does and doesn't support. But it may not support early angioembolization. So at the end, your guideline is these are the opportunities, for taking care of the patient with a splenic injury. However, early embolization is not supported or not recommended, or it's a conditionally recommended, very weak recommendation. So does that kind of make it a little clearer?
Actually, it really helped. So really, your lit review is so important, because once you do your lit review on whatever it is that your interest is, then from there, you're going to evaluate maybe, so do we need to do something different? And if so, what are those changes that we need to do based off of the literature you found that you're going to grade?
This is true. You have it. That's exactly it.
Okay.
Vicki, do you have anything to add to that?
No, I think you've done a great job explaining. I would be interested in who actually is on the call and their role in I think they're all part of the clinical committee. Is that what I understand? And how, if anyone on the call has been motivated to learn more and is excited about this, or if this has kind of cleared the cobwebs and people are disinterested. I think there's nothing wrong with either one of those decisions. I would just be curious myself. I don't know about you, John.
Yeah, I would too.
Brian, are you going to give that information, or?
I'm sorry, can you repeat the question?
Yeah, I just asked who was actually attending the call, if they were all members of the clinical committee.
Yes.
If we didn't really have an introduction or know who all is on the call, if that's not something that we need to know, that's okay. I was more curious if we were able to establish a level of interest from the attendees, if this has actually motivated them to want to learn more and it was something they were interested in, or if this is something that has cleared some of the cobwebs to know that they are not interested in it.
It is just the clinical committee members. I can't, everybody is open if they want to discuss this. I know that the plan is, Linda, correct me if I'm wrong, to discuss this on our regular meeting to see if we can do this or get some outcomes from it, from this. I do have Ashley Metcalf is in having some difficulty with the noise, but would be interested in moving forward. Like that.
Yeah, Brian, I can't hear you. You're breaking up a little bit, but I got enough to know that I believe that you're going to discuss this on your next call, and maybe Linda then can just provide us with a summary of those that she feels would be most interested in working on a project with us then.
That's correct.
Okay, great. Thanks.
And just for this group's information, we have actually submitted a proposal, TraumaCon next year, to actually do a panel discussion with Dr. Como, Vicki, and I about grade. Vicki will discuss in that panel discussion how to take it from paper to bedside, which is a struggle we often face when you're looking at guidelines and how to implement it within our own institution. And I'll actually be talking about starting process and what it's been like working through a PMG, and hopefully we'll be pretty close to manuscript time by the time TraumaCon comes around next year on the current one that we're revising. Well, once again, thank you very much for having Vicki and I. If you have any questions, feel free to email. Does anybody else have anything on the call? Okay, if not, Brian, I think we're going to conclude the call.
Thank you, John and Vicki.
Thank you.
Thank you.